going to start out with Dr. Oscar Serrano, who's a transplant surgeon at Hartford Hospital, and he's going to start us off with a presentation of a very stimulating paper, and we'll go with Oscar.
Thank you, Carlos, and good evening to everybody. I'm going to share my slides. All right, can everybody see that?
Yes.
Yes, looks great. Thank you.
Great. So, as Carlos said, this is an initiative that was basically thought of by him and the New England Surgical Society's leadership. We're trying to stimulate the discussion of hot topics around surgery, and in this particular case, transplantation and oncology. So I want to present the article that we're going to be talking about, but the majority of the discussion, I think, should be had by the primary author, who we're fortunate to have here, as well as several other senior transplant surgeons in our area. So the title of this article, which was published in JAMA Surgery, is Recipient and Donor Outcomes After Living Donor Liver Transplantation for Unresectable Colorectal Liver Mets. As most people in this audience know, colorectal cancer is the third most common cancer worldwide, and more than 50% of patients will go on to develop colorectal liver mets. Most patients with liver-only disease, unfortunately, are unable to receive curative surgery for a variety of reasons. Namely, they may have bilobar disease, or they may have an insufficient liver remnant. Now, transplantation for unresectable colorectal liver mets is a relatively new topic, and it's a very new topic in the West, but it was actually started in Scandinavia. Most people in the field know of the SECA or SICA trials that were performed in Norway. In 2013, that's when the first experience was published from that group in Norway, where 21 patients with colorectal liver mets had a liver transplant, and they had an overall 5-year 60% survival, which at the time was pretty revolutionary. They went on to perform the second trial, in which they selected patients a little bit better. So the first trial basically had all comers with different tumor biology and different characteristics in terms of their risk score. But with the second trial, 15 patients had a transplant with relatively low risk for recurrence characteristics, and they had an 83% 5-year survival rate. From that group published and developed what is now known as the Oslo score, which is the score between 0 and 4. And you can see there the characteristics that would portend a favorable outcome or a poor outcome after liver transplantation, and that deals with tumor diameter, the level of CEA in the bloodstream, the interval between liver transplantation and the primary resection of their liver met, and having stability of their disease or progression of disease at the time of the liver transplant. This was somewhat similar to it's always been compared to the Fong clinical risk score that I think a lot of people know for liver resection. And you can see the correlative characteristics. So in this particular paper, this was a prospective multi-institutional trial at the University of Rochester in Rochester, New York, at the Cleveland Clinic in Cleveland, Ohio, and at the University of Toronto. This was an independent treatment protocol adherent to the consensus guidelines for this type of endeavor. In other words, transplantation for colorectal liver mets that is put out by the IHPBA. This was a prospective trial and a prospective evaluation that occurred and enrolled patients between July of 2017 and October of 2020. And the liver transplants occurred between December of 2017 and May of 2021. The oncologic surveillance after liver transplant was left up to each institution. And the last day of follow-up was May 1st of 2021. Overall, 91 patients were evaluated. Only 12 had disease control that was to be considered for liver transplantation. So that was 13% of patients. However, 2 patients had a high MELD and therefore received a deceased donor liver transplant. So ultimately, only 10 patients went on to receive a living donor liver transplant. So 11% of the cohort that was evaluated. Here you can see some of the clinical, demographic, and oncologic characteristics of patients. As you can see, the majority of patients were in their 40s. They were a relatively young cohort, low BMI. Most patients had either a moderately differentiated or poorly differentiated primary tumor. The majority, or 90% of patients, had synchronous colorectal liver mets at the time of presentation. You can also see here that the majority of patients had a median number of cycles for chemotherapy of 22. But up to 37. Most patients either had prior liver resection or some other liver-specific therapy, such as a hepatic artery infusion or tumor ablation. And as you can see here, the median clinical risk score, the FONC score, was 2.5, and the median Oslo score was 1.5. So overall, what is considered low-risk characteristics for recurrence. The time between the diagnosis of a colorectal liver met and liver transplant was about 1.7 years. So remember what we talked about before in terms of the time interval. And as you can see here, the overwhelming majority of patients had bilobar disease. Here are the 10 patients and the characteristics of the treatment that they received prior to undergoing liver transplantation. You can see a variety of different treatments, such as FOLFOX, FOLFIRI, targeted agents, all kind of standard of care for patients with metastatic colorectal liver mets. Some of them had resections, some of them had ablations, and again, the time to from diagnosis to the actual transplant was on average 1.7 years, but some of them up to 7.5, 7.8 years. Here are some of the characteristics about the actual transplant and the donors. The donors themselves, as would be expected, were young, healthy, lean. The length of stay for the donors was about 6 days, which is pretty standard for a living donor at a large volume living donor liver transplant center. And I do want to point out the complications, which is always something that we must weigh when we're evaluating someone for a living donor liver transplant, which is the complications. They had 1 out of the 10 that had a significant or clavien-dindyl grade 3B, which was basically a hematoma that needed to be evacuated through an incision and drainage procedure. Here is the explant pathology of the livers that were removed. As you can see, 90% of patients still had a viable tumor. The underlying histology in about 50% of patients is they had a normal liver. And as far as the complications for the recipients, we see that they had complications similar to living donor liver transplant recipients that are having this done for non-colorectal liver mets. And these were clavien-dindyl 3A, 3B, such as bile leaks, bleeds. They also had 1 hepatic artery thrombosis that were successfully declotted and was able to not have a graft loss from that. So I think this is probably the significant figure in the paper, the most significant figure in the paper, in which the survival occurred. So overall, with the median follow-up of 1.5 years, recurrence was observed in 3 patients. So they had a 30% recurrence rate. Interestingly, most of the recurrences occurred less than 200 days out. So of the 3 patients, 1 was at 92 days, or 3 months after the transplant. 1 was at 4 months, so 121 days, and 1 was at 199 days. All 3 patients were treated with palliative chemotherapy, and 1 died within 3 months of the treatment. So overall, in this analysis, the recurrence-free and overall survival at 1.5 years was 62% and 100% respectively. So the points for discussion is living donor liver transplant per this study demonstrated an alternative to colorectal liver mets without having to put a strain on the deceased donor wait list, which is often a barrier, at least in the Western world. Of course, we talked about the potential benefits to the recipient that must be weighed against the donor risks of having such an operation. Talked about the patient selection of patients after 1 year of having their diagnosis and having some stability to their oncologic process. And again, favorable tumor biology, I think, is what will drive the success of this operation. There was an editorial that was written by several senior liver transplant surgeons, and they were similar to what their comments in this editorial were similar to what I've just outlined. That for one, this was 3 different protocols and candidate selection processes at 3 different institutions, since that was some of the variability here. There was also variable surgical treatment for the liver mets prior to the liver transplant. It's unclear, based on the results of this study, what the overall tumor burden was at the time of the liver transplant. And the biggest problem that I think people saw in this study was the early recurrence of 30% within 200 days of transplant. Finally, even though 91 patients were evaluated for this protocol, only 10 went on to receive this treatment, which speaks very highly to the selection of process of this. So in their editorial, they also speak about the importance of understanding tumor biology prior to undertaking any of this. So I thank you for your time. It's been a pleasure to present this article. I'd love to hear what Dr. Hernandez and Dr. Eckhoff have to say about it. Thank you.
That was wonderful, Oscar. So, I mean, I'm sure that everyone in the crowd can imagine this is still quite a controversial topic, right? When we talk about the donation of living organs, it's a difficult dichotomy, right? We, essentially we're subjecting healthy people to potentially lethal outcomes in an effort to try to save somebody else. And so it's a very difficult undertaking, and it really requires people that are very high level of expertise, and the teams that they incorporate into all of these. And I'm sure it'll come in as no surprise to folk that this is still very controversial, and you could poll people across the country, and I'm sure there's a lot of people that say that they're absolutely and adamantly opposed to it. Even Dr. Starzl at one point in time, and it's not clear to me if by the time of his passing, he'd really come around to live donation, but he had some serious reservations. Given the controversy of this topic, but it is very timely and necessary. As Oscar said, part of the issues that we're confronted with as transplanters is a shortage of organs. We are really fortunate to have both Roberto Hernandez and David Eckhoff. Roberto is the chief of transplantation at University of Rochester, and Devin Eckhoff is the chief at BI Deaconess. In a sporting fashion, we're going to allow them to sort of duke it out, if you will. It's just a pun. But Roberto has been invited and has graciously agreed to present his position on this, and he will present the pro side of this part of the debate at this point. Roberto, thank you very much for your gracious willingness to participate.
Thank you, Carlos. I hope everybody can hear me. Thank you very much. It's a pleasure to be here. It's a great honor to be invited by you, Carlos, by the New England Surgical Society. Cheers for you, Carlos. I like this topic of happy hour. So I don't know if everybody needs to have a drink in their hand or not, but I can see that you already have one, and so I did the same. So cheers for everybody. Oscar, you did a fantastic job. I met you before, and I always knew that you were going to do well. David, it will be a great honor to be hearing your conversation and your presentation. So with that, I will start my presentation with you guys, but I will have to share first my screen. Tell me if you can see my screen. All right. Clearly, Carlos state that this is controversial, and it continued to be controversial. And the only way that we can move it to the other side is just getting familiarized with this and showing results. And that's what we're doing. So this gentleman here that is in this picture that passed away like 3 years and few months ago, if he would start doing what he did many years ago, if he would start doing today, probably he wouldn't be allowed to do more than 2, 3, 4 cases. Maybe he will go to jail. And it was extremely controversial what he did at that moment. The outcomes was terrible. There was no good immunosuppression. And Tom Starzl clearly mentioned that you know, if you want to do innovation and you believe in that, you need to continue trusting in that. And a lot of people will be against you, and but you have to show that it's good. Interestingly, look at this picture. Here he is, and he's wearing a watch, right? Look at that. He's right. That's interesting. I don't know if he's cropped with that one or it was just for the picture of here. But this is the way that I feel with all of you guys. Like I feel like I'm going to the wolf pack, and hopefully you turn to be like a nice wolves. Carlos, you choose a very good presenter, and it was Oscar. And Oscar clearly showed that colorectal cancer is a big problem. Third most common cancer of cancer. Around half of the patients will develop liver metastases, whether they are diagnosed at the beginning or in the next few years. And if you can see in this table in the right side, clearly in the United States, due to our colonoscopies and prevention teams, it's decreasing the incidence of colon cancer in the older population, which is where we normally see. But look at the 20s, the 30s, the 40s, it's going up. It's going up. And we only do colonoscopies from 45 to below. So you can expect to see this going up. Why is it increasing in this population? I do not know. My wife clearly said that this is the diet that we eat. And I think she is right. But this is what we see in clinic. This is what the patients that we're talking about, and I want to frame it. I don't think anybody here, and we will bring a lot of liver surgeons, nobody will say that this is resectable disease. This is unresectable disease, and this is the patients that we normally see, or I at least normally see in the clinic to see these patients. Dr. Tomiyama is here with me from our University of Rochester, and we both run this group, and so I am glad that he's here, and he sees the same type of patients. What happened to them? The treatment is chemotherapy. And we know that the chemotherapy will be a 5-year survival of 5 or 10% in the best cases. Many of them not going to make it in 1 or 2 years. So this is the outcome of these patients with the best chemotherapy, even some of them with the hepatic artery infusion chemotherapy. And Oscar clearly mentioned about the Norway group, and I just want to revisit this very clear about, we have to be cautious in this paper because they only talk about 16 patients, where they talk about this Oslo score. The more parameters you have here, the worse the outcome. But if you have 0 to 1 or 2, you can see that these patients will have a pretty good survival. You know, we have been doing liver transplantation for HCC for many years, since 1996, right? And the outcome of the survival of these patients here, it's better than those ones. Recurrence is different, but the outcome of survival. So does the patient care about if he has cancer, or the patient cares about if the patient has recurrence, or the patient cares about survival with good quality of life? The group from Norway also not only were able to show the good outcomes with the Oslo score, they also showed that there is this MTB score of using nuclear medicine scans, where they calculate with a formula if the tumor uptake was less than 70 centimeters cubic, the outcome was pretty good at close to 80% at 5 years. So now they're bringing another tool to assess and super selective. So this is, Oscar was saying that Shimul Shah mentioned you're super selecting, and that is the medicine. That's what medicine do, and we do it every day. We're selecting which are the patients that we're going to be able to offer them a better treatment, a better surgery, a better outcome. We don't do surgeries in patients who we don't know, like they have metastatic disease in the bones. Well, that is selection. We know about that. So I think that shouldn't be a critique. That should be something good that we're looking after that. Interestingly, just to show to the audience here, is that if we know that when we do liver resections, and I am an HPV surgeon in Canada where I was trained, liver transplant surgeons we do, and I'm an HPV certified surgeon through the AHPVA. So I continue doing a lot of liver resections. When I was in Canada, I was doing more liver resections than liver transplants. And we know that partial hepatectomies in colorectal liver metastases, they have recurrence rate very high in liver and in multiple sites, including the liver as well. While in liver transplant, in the data that we have, it's only 3%. That is something really, really interesting. Why is that happening? Well, simple. We're removing the liver with all the microscopic metastatic disease or the disease that we cannot see. And interestingly, again, those patients who have recurrence in the liver after transplantation in Norway, they have a poor outcome compared to those ones who have recurrence in the lungs. And interestingly, also the patients who have in the lungs, they can be treated, they can be resected, and not necessarily require chemotherapy, and they go to no evidence of disease. Bingo. 10-year survival. The first paper recently, I don't know if it was just still electronic only, but this is the survival at 10 years. We can see, yes, it's true that around 75% of the patients will have recurrence. But look at this survival at 10 years. This is quite impressive. We never thought that we were going to be able to have those outcomes in these patients with 10 years overall survival. Some of them better than the liver transplant for cirrhotic patients that we're doing. And survival after relapse, what I was talking about, the patients relapse, they can be treated, they can be resected, they can receive chemotherapy. There's no problem of getting chemotherapy with immunosuppression. There's no evidence of any bad outcome of that. So another important topic was what happened with living donation. So clearly, a lot of people, and we have transplanters here, is that we have around 20% of our patients will never make to the transplant to the top of the list, especially if you live in California, especially if you live in the Northeast, which a majority of you are from in the Northeast. There are longer waiting times before receiving a transplant, and also the patients are going to get more debilitated. Not all patients could benefit are listed on offer at transplant. This is the advantage of living donor liver transplantation. Carlos mentioned, yes, this is controversial. Well, let me tell you, there's more risk of jumping from a parachute in an airplane than getting a living donor liver transplant in good hands. And we don't tell people don't jump from a parachute. They do whatever they want. What are the disadvantages? Those risks of the donors. What are the advantages? That's the best organ. There's no better organ than a living donor liver transplant, let me tell you, because these are patients with a low BMI, no fatty livers. Even that is a partial liver, we do it during the day hours. Transplant prior to recipient becoming critically ill, minimal cold ischemia, immunological advantage adds to the cadaver pool, and there's a financial benefit as well. So clearly, there's huge advantage if you are in good hands. Why it has been highly criticized? Because of the donor deaths, and we live in a country where if you have a bad outcome, it's pretty go out in the media, and it gets a big problems, right? There are other things that we do in Whipples for patients with pretty bad outcomes, and we continue doing it without any major risk. But this is a pretty good interesting study, and clearly is like around 1 in 1,000 and 1 in 800 of donor deaths. What is in the literature, and I would say that in a study done by UCSF recently is around 1 in 1,500, but it hasn't been published lately. My colleague that is going to be presenting after me, Dr. Eckhoff, clearly showed him here in this study in the US, right? And he mentioned that we need to do more living donors, and he was showing here with these colleagues here that living donor liver transplantation is something that we should be doing because, look at these outcomes are pretty good, much better sometimes than some of the disease organs. And in the conclusions and the summaries, he said that we need to really give more exemption points to those patients with HCCs, that we should be using living donor liver transplantation more often, life-saving policies to increase the use of living donor liver transplantation, especially in regions with high organ demand. So I clearly see that Dr. Eckhoff, it's pretty open for living donor liver transplantation to helping patients with cancer. Of course, at this moment in this paper, there was not too much into colorectal liver metastasis, but he is clearly showing here that he's okay with the safety of the patient and doing this. And of course, we need to be thinking about double equipoise. We shouldn't be putting the life of someone on risk if we're not going to have a potential good outcome. Right. And with the studies that we have, we can clearly show that if we select the recipient correctly, we can have good outcome. So what we did in Rochester, we created a clinical trial to start this. This is our criteria. We use the Oslo criteria that you can see here in the right side, but also we went more detail in what we have been doing and more selective. Clearly, there's you can see here progression on the chemotherapy is part of the Oslo score. If a patient is having progression on the chemotherapy, despite it's the only point, that's a contraindication in our program. If the patient has a CA above 80, even if that's the only score, it's a contraindication. We have in Rochester, the paper that Oscar presented, it shows 3 institutions. This is almost 200 referral. Of those ones, we evaluated 163. This is men and women that it's a little bit different. Majority of the tumors are in the left side. We know that there's a higher risk in the right side tumors. And interestingly here is we have done 17 of these transplants, and 16 are still candidates. Some of them are waiting for a living donor only. Others are waiting to complete the time of observation. But almost 80% of the patients drop out of the protocol at the moment of the evaluation because they have extrahepatic disease, so they were progressing, or during the follow-up of these patients. So this is showing that we are selecting the patients properly. This is an updated overall survival of our 17 patients, 90% survival at more than 3 years. This is better than what we have been showing, the Oslo score or Norway. Of course, I don't want to get excited. We have to wait a little bit more years. Now, this recurrence is showing very similar to what happened in Norway, but this is a short follow-up period of time. We have 4 patients who have recurrence. Only one died out of the 17. So because the ones who have recurrence are in an early stage of when they get the transplant, so then the patients who have shorter follow-up, that's why the curve comes down. So I would expect if we have better outcomes and lower recurrence, this curve will come up. But despite that, the overall survival and the quality of life of these patients is pretty impressive. And this is what our research fellow find. Mariana, she's working with us for 2 years doing research here. And the left side livers here, the center, and the one in brown is the pathology, the explant of all the liver transplants. The one in the left side is the one that when they were the CT scan or the MRI when they were diagnosed with colorectal liver metastases. And the one in the center is the one imaging that they have before the transplant. And guess what? 64% of the patients have more disease of what we can see in the imaging. What is this telling us? These patients have more disease. So when we do resections on those patients who have response, why they have recurrence is because they're diseased. So probably a lot of the patients that have resectable disease in imaging probably would benefit from liver transplantation. This is happening in the US, and I might be missing nowadays some. It's not updated over the last maybe 7 months. This is the centers that are doing liver transplant. But this is here. It's not going to live, and it's continue growing. And we published this paper with Dr. Kazu Sasaki. Koji Tomiyama is also here in this paper. And this was published in a group from all the transplants until 1.5 years ago, 48 liver transplants in the US. Majority of them with living donor liver transplantation, some of them with diseased organs. So you will say, how do these patients get diseased organ? Well, wait a moment. This is because some of them, they have higher MELD score. And these are the patients who have more treatments, they have more pumps, more radiation, they have liver dysfunction, burnout liver, burnout cancer, but at the end, they still have some cancer, and those are the patients who have worst outcome. They have more mortality within the 90 days, and they have more complications rate. The organs that these patients received probably were not the ideal. There were disease organs that a lot of, or DCD organs that a lot of other centers turned down, and they use it in these patients. So it is important that we need to learn about if this is more from the graft or is it more from the recipient. Unfortunately, with the UNOS database, we cannot that. And just to summarize here, I want to show some examples. This is a patient, 54-year-old. There's no, it's wild type, there's no mutations, and the CA responded very well from 280 to 5.4. Look at these patients. I started with that, my talk, and the response was impressively well. A lot of people will say, oh, maybe I can resect that. Wait a moment. We did the liver transplant. These are Koji Tomiyama skills with those grafts that we reconnect B8 and B5, and there's no congestion here. And there is more disease that we can solve. That's what our fellows show. On this other patient, you can see the metastasis in the left side, in the right side, in the center. Maybe someone will say, okay, I can ablate this one and do a right hepatectomy. All right, the patient received chemotherapy, responded. You can see one metastasis here, this big one calcified, and then you'll say, okay, I'll do ablation here and do a right posterior segmentectomy here. Look at the liver. This is that same patient. These all tumors were active, some of them necrotic. So if you would do that, this patient will have recurrence in the recovery room. And this patient is out of cancer. So just to conclude, liver transplantation and living donor liver transplantation, I think it's underutilized in many countries, especially in this one. Excellent outcomes can be achieved with liver transplantation in selected transplant oncology patients. And some of them could be cured. Other ones will have a much better overall survival. There is a need of a national registry, and the University of Rochester got the award from the American Society of Transplant Surgeons, and we're opening the national registry of colorectal liver metastases through a big grant that we got internally. And this is a national registry, and we'll continue. And I think all the cases need to continue with the trial. This field is quickly evolving, and liver transplantation is not part of the surgeon's toolbox, and patients should be offered this option. With this, I say thank you very much.
That was wonderful. Thank you very much, Roberto. You have clearly mastered this area, and potentially, I would say, one of the pioneers of transplant oncology. That said, you know, every coin has two sides, right? And so at this point, let's welcome Dr. Devin Eckhoff from VIDEC for the opposing viewpoint. Devin, thank you again very much for your gracious willingness to participate. Well, and I hope Roberto didn't throw you under the bus with suggesting that you're actually on the pro side before you've even spoken.
Well, thank Carlos for the great invitation. I always love these debates and discussions. I end up learning more just by preparing for these. One of the last ones I did was at the ASDS Winter Symposium arguing about how to do the CAVA. And I walked back after I lost that debate and changed how I did the CAVA. So maybe that'll happen here. So if you got a hammer, you use a hammer. Right now, we don't have a living donor surgeon. Tomorrow, if I hire one, maybe we'll be doing liver donor for colorectal. But I applaud Roberto and his work he's done there. It's pioneering. I think we agree on more things than we disagree. I don't disagree with doing liver transplantations for colorectal. I probably don't disagree with doing liver donor in certain situations, but I think the evaluation and use of livers has really evolved over the last 3 or 4 years. So again, and what we previously thought was unacceptable or not good livers, no risk. There's new tools, there's new technology that allows us to use livers. and assess them before we put in. And it allows us to use livers that were previously thrown in the bucket. This is showing their great work, and we could see the percentage that are done by deceased donor versus living donor. I think this is outstanding work, and it takes great surgeons to be able to have these kind of results with living donor. What I wanted to look at is when they did this table talking about how sick and how marginal these livers are, quite frankly, this year I consider all of these sort of standard donors that we use frequently. They only use 2 deceased donors. Now with the pumps, over half our donors are deceased, donation after circulatory death. For those of you that aren't transplant surgeons, these are people that don't have brain death and they withdraw life support. And then you wait till the rest and you procure the organs. Historically, when you use these livers, they would get what's at a pretty high frequency, anywhere from 30 to 40% ischemic cholangiopathy. And a certain percent of those people would need to be retransplanted. So that landscape's changing. They talked about these fatty livers. There's actually only 2 livers they used that had more than 30% fat. Anything less than 30 or 40% fat in any kind of big or aggressive center, which all the centers that do these are, they probably routinely use these type of livers. The age, the liver doesn't age the same way as other organs. So they did use an organ that was from a 73-year-old donor. There are certain ones that you can get away with that. And we've used several in the late 70s. And if you carefully pick your right patient, and I think a patient that has in their 50s or 60s with metastatic colorectal cancer, that would be an appropriate patient for some of these. So the results are pretty good with that. So the challenge is, this was a Swedish study that looked at it, and they came, and it's a prospective. There's not a lot to talk about this study, but they were going to look prospectively at from extended criteria donors, not just using living donation. And a lot of the European, that Oslo study was initially with just living donor. They have a different supply and demand dynamic than we do in Oslo. So it made it easier to use some of these livers. So I spoke about the technology. For those that aren't transplant surgeons, one of the newest things is this machine preservation of organs. And you can do it at low temperature, you can do it just below room temperature, or you can do normal thermic. And the beauty of these is that the livers are preserved better. You can extend the preservation time, so you can wait longer to do it. And as I'll show you later, we've got a lot of organs that were either turned down in the OR or after they were put on the pump. And we'd be able to watch these livers from anywhere from 10 to 20 hours and see how they function. Previously, you would take a liver that you weren't sure how it was going to work. You take it out and put in a cooler with ice. Then you put it in and you kind of hope and pray that thing's going to work. Now we have the capability of putting these livers on a machine, and they'll correct their acidosis, the lactic acid will correct, and they'll start making bile. And if they do all those 3 things, there's like a 99% chance, or if not better, that those livers are going to work. So it gives you have a functional assay to look at some of these marginal donors. So that's really turned what we consider extended criteria marginal donors on its head, and allowed us to be much more aggressive using these donors because we know that they're going to work. So a lot of my focus is going to be on the impact of XI2 machine preservation, normal thermic. There's 2 different platforms. I'm not going to be a salesman for any one of them. We've happened to use a lot of Transmedics livers, but I also used Organox, and I think it's the technology. And I don't know whether it's going to be hypothermic, subnormal thermic, or what's going to win out. But I'm going to tell you, this is going to revolutionize transplant. We're going to go from being up all night doing transplants. In a few years, they're going to figure out the money. And we recently had a speaker from Duke. Not only do they use them from deceased donor, they use them for brain dead donors, and they're doing it for almost 90% of their donors. So if you can work out the money, it makes the logistics of your team much better. You're not having an operating team burned out operating all night. You can schedule them during the day. And if I do a liver transplant starting at 8 a.m., I can do probably 1 every day of the week. But if you do 2 or 3 at night, it shortens your career, and it's hard to do anything else. So this is the new paradigm of acceptance. I think enough people on this call may be old enough to remember Nancy Reagan and the just say no to drugs. You get all these data points on organs, and it's in the middle of the night. The CT says it's fatty. They say that the person's over breathing the vent. They say that they're not going to arrest on time. They say the BMI is 50, and it's just easy to just say no. You don't want to compromise your results. You can't only take so many hits. We're held to such a high standard of our results. But I argue that we just need to say yes. And I'm not trying to be a joker about it, but you just need to say yes. You need to go and actually look at these organs. And the beauty is that some of these companies will go get them for you. They'll put them on the pump. They'll do this. You'll get a functional assay, and you can use a lot more organs than you could previously use. So I'm going to show you a few examples of livers that nobody wanted. So here's a picture of a liver from a 60-year-old donor. They did a biopsy. I'll show you the biopsy. 60% macrovesicular fat. I would never use a 60% fat. Some of these people die on the table when you reperfuse them. They get cholestatic. They get acute kidney injury. They hang out in the hospital a long time. This liver was accepted by a program in New York. They put it on the pump. They slept all night. They came in the morning and decided they didn't want it. So we got a call. The acid base status was good. The pH was good, and it was making bile. So we accepted this liver. We put it in a person. It had 30 hours on the pump, and it worked beautiful. So the point is not that we're cowboys. The point is that there's a lot of livers out there that we're going in the bucket that we can do. So if you can be aggressive, it's great. Maybe living donor is going to be the only option for some people, but there's different ways. So this is another example for you. This donor, I've never taken a liver from a donor this big. He weighed over 450 pounds. The BMI was 62. The liver weighed 4.5 kilos. It was bemuth. On the right side, you see what a normal liver looks like in the machine. This thing took up the whole cassette. If it was any bigger, they couldn't have done it. And I'll just show a quick clip. The transplant surgeons have seen this, but you perfuse oxygenated blood with nutrients in through the portal vein and the hepatic artery, and then you can adjust it, and you can get a good readout. You can watch these things 10, 12 hours. That gave us a leisure to call in a patient that was a large patient with ascites that we could put this liver in. I probably shouldn't be showing this because he's not quite left the hospital, but he's on the floor doing well. But it shows that there's livers that previously that we're throwing away. And I'm going to show you a slide in a bit, just about the potential outcome for those livers. These are two livers. Logistically, I think we did one day. We got two more offers. We put them both on the pump, and we did them both during the day, one to follow each other. And we would have turned these down, and a lot of these would have been discarded. On the right is Dr. David Lee. He's someone we recruited from Loyola. Between him and Marwan Kazmi, I at one time thought I was aggressive, and I learned what being really aggressive is and looking at these livers. And some of the parameters that we typically used in the past are being thrown out. And that's mainly from this machine perfusion. They usually have to arrest within like 30 minutes. Now we will keep them as long as the critical time we look at is from when the systolic blood pressure is less than 50 to when they're flushed. And we'll wait up to an hour, and we'll wait up to 15 minutes for it to flush to occur, and we'll put them on the pump. And there's a lot of these livers that were right around 30 minutes that people threw in the bucket and never used. So I think there's not just tens, there's probably hundreds, if not maybe 1,000 more livers a year that we could get if everyone became more aggressive. Sorry about that. This just shows how many livers are being pumped. It's kind of skyrocketing. The overall number of DCD livers being used a year is about 1,000. Then on the right, you see there's about 200 to 300 livers a year that are procured from DCD livers that are discarded for some reason, that they feel uncomfortable. I don't know if it's biopsy, but I would argue with you, if you put these on the pump, the majority of these would be used. And that's only the tip of the iceberg. There's other livers when they go do a DC donor that they never even pull out, that don't even get discarded. There's about 5,000 DCD donors a year, and we're using about 1,000, 20%. I think if we raise that up to like 30%, that's almost another 1,000 livers that we'd have. So there's quite a bit more livers out there, and it would make doing these transplants much more appealing for everybody. There's probably, I still think, a role for living donor, but I think we need to exhaust this avenue of using these livers. So this is going to be another little video clip. We started using these livers just in February, and this is showing where we get our livers from. They come from all over the country. Red is going to be brain dead donors as we go it, and this is by month. And you can see how our practice pattern changed just during this Let me. Our practice pattern change, how we're getting livers, Puerto Rico. Now we're pulling DCDs out of Georgia, Alabama, South Carolina, Texas. And the way the allocation works is these organs are prioritized to people within 150 miles. So those organs we pulled out of Texas and Alabama had to be turned down by every center in the Southeast. So, and we put it on. And there's Dr. Lee's looking at this, like people look at the Glasgow Coma scale, they look at the overbreathing event. It doesn't mean anything. There's no predictive value. I think the main thing is who's withdrawing life support. And there's things that we don't know by looking at some numbers in the UNOS report. This shows how our approach has been. The red circles are ones we're using brain dead donors. Those are typically for our higher melds. We're pulling brain dead donors out of the Northeast, region 1. The green boxes are DCD, and it's showing that are pumped, the green triangles. And we're able to get people that have been on the wait list a long time, people with lower melds transplanted. Most of these have hard indications for transplant, tumor, medically refractory ascites. Then there's some lower red circles. Some of those are expedited placement, and I'll show you a little bit about that. Briefly, I just call your attention to expedited placement. There's over 15 organs. These are ones that already been cross-clamped, and there's about another 10 where they just gave us open offers. So in the last 6 months, we've gotten and transplanted 20 to 25 organs that were just orphaned, that would have gone in the bucket. And those, obviously, you could jump down and do people with low melds. We did some low melds here, as you can see the range, particularly in the pump ones. So it'll allow you to drop down and get some of these people that had colorectal mets. This was mentioned. The people that do living donor surgery they always got to be successful and have a successful program. You have to be very good technical surgeons. So this just comes with the territory. This is just the complications from doing very complex surgery. But I wanted to end showing you, I also put the table together of the complications we see in the deceased donors. They all die, not like a rarity of the living donors, which is a tragedy. But this is the list of the complications in the deceased donor. There is none, right? They're all going to die. They die. There's no hernias. There's no bile leaks. So the risk to these deceased donors. So I guess I'd finish that. I think it's great work. It's important work people doing living donor. I think there's other options, and I think that we can utilize some of these organs. We've done 102 transplants for this fiscal year, and about 50 of them have been deceased donors. We have one person on the list waiting for a retransplant, that their artery had a dissection afterwards. So far, none of the rest have needed a retransplant. So we have over 40 of deceased donors that we've done, and we put pump, and that they're all working. Some have gotten some minor cholangiopathy, but it's kind of resolved with time. And none of them, only one, like I said, is on the list. But happy to hear counterpoints or argue any other or debate any other questions.
That was beautiful. Thank you very much, Devin. So in the true spirit of a debate, I think it's important to allow Roberto a little counterpunch. Oh, you did say point. Roberto, how would you respond to Devin's eloquent discussion?
Thank you, Carlos. Devin, thank you very much for your presentation. Nothing that I have to go really against you. Clearly, the fact that you didn't talk about liver transplantation for colorectal metastasis clearly is telling me that you support to do liver transplants. It doesn't matter what type of graft. Liver transplant for selected patients, which that was not the topic of your presentation. The topic of your presentation was based on the graft. And let's see, there's the gap between the number of liver transplants and the patient on the waiting list is huge. And I agree with DCDs. The first part of my career, if you search me in PubMed, I have several dozens of papers on DCDs. That was when I started my career and when I started to get academic. So I'm a big fan of DCDs. And when I moved here to Rochester, there was PTSD on DCDs. People didn't trust that. And I have the opportunity as a fellow to do the first DCD in Canada. And I say, well, that's my career, and I have been doing that. So I want to show the people here, and of course to myself, and that we can do DCDs. And nowadays, probably 10% to 11, 12% of our patient transplants are DCDs. So I'm a big believer on DCDs. We're recently starting using NRP. We participate NRP. We have done hearts NRP on DCDs, which is normothermic regional perfusion. We have done 3 liver transplants with NRP, DCDs. We participated in a trial with hypothermic perfusion with other 10 institutions, and this was started with in New Jersey with James Guerrera, which he was one of the pioneers of the hypothermic perfusion. So I think we need to use DCDs. We need to use living donors. We need to use partial grafts. There's a lot of room because there's not a single answer. Clearly, for me, the message is liver transplantation for colorectal metastasis. If you have a good organ, you can use it and transplant it. We shouldn't be using bad organs in patients for experimental. I think the DCD NRP is going to be increasing, and it's going to be answering a lot of problems for a lot of our patients. But the other thing that just specific with that, in my experience with colorectal metastasis, is many of these patients, they have a MELD score of 7, 8, 9. Many of them. They are a little bit devastated because of the chemotherapy, but not as bad as our cirrhotic patients. Not as bad as our cirrhotic patients. If nobody has touched the liver, there are beautiful transplants to tell you the truth. And Koji is here because he's do the majority of the recipients. And he can clearly, like, these are beautiful liver transplants that we can do. But the problem is, I don't know how to justify if I'm having an offer and I have a good organ that nobody wants it, and I reperfuse and I put it in the pump and I see that it's good. How am I going to skip a patient with a MELD score of 19, 18, 17, and put it in a patient with a MELD score of 9? That's hard to me to justify that. I don't know. It's hard to me to
Those are all hard.
And also, the big advantage of living donor liver transplantation in this subset of patients with colorectal metastasis, the advantage is that you plan the treatment with chemotherapy. Also, you can plan the treatment with the patient received chemotherapy and Avastin yesterday, and you're going to do a transplant today because you got an offer for them.
Those are all difficult questions. And unfortunately, at this point, we're going to have to pull up the proverbial red light. Those are great debates. Those are great and very important points. And the timing of all this is important. And but, you know, there are 2 other people that have joined us, that people who may say that, well, potentially with the armamentarium that is at our standard disposal, we also have the capacity to do a great deal of good for patients with presumed irresectable colorectal metastases without jeopardizing a donor. We'll turn first to James Lineberg, who's a surgical oncologist at UMass, and we just want to hear his points, and then subsequently Bert O'Neill, to give a whole spectrum of discussion and exposure to the topic. James, thank you for joining us.
Yeah, thanks. I'll be brief given the timing here, but thanks to Dr. Hernandez, certainly in the group, for looking at this issue, particularly on protocol and prospective fashion. Congratulations. These are terrific outcomes. And I think from the surgical oncology perspective, I often feel like Dr. No when taking care of these patients, because so many of these people, either at diagnosis or throughout the course of their treatment, become unresectable. And so aside from the patient-specific characteristics and biologic concerns, ultimately what drives that resectability determination is really based on the limitations of the future liver remnant that we have to work with. And so for those on the call who don't do liver surgery, our liver remnant, we need to preserve adequate vascular inflow, outflow, biliary drainage, and adequate volume to support normal hepatic function. And in the case of this patient population who's likely had extensive chemotherapy, that future liver remnant needs to be at least 30% of the pre-resection liver volume, or 40% for individuals with pre-existing liver disease. And we have a number of creative ways to get around that to achieve a margin negative resection in these patients, either through parenchymal sparing non-anatomic resections, standard anatomic resections, two-stage hepatectomies with portal vein embolization, ALPS procedures, hepatic infusion pump therapy, but ultimately we'll end up running up against the same barrier of an inadequate future liver remnant, either from the outset to clear the liver of disease, or an inadequate function or volume to support further liver-directed therapy in patients who develop a recurrence in their remnant liver after a prior resection. And so to that end, transplantation to me seems like a wonderful solution to a future liver remnant problem, as it becomes a moot point here. And cancer-directed therapy can really be driven by the individual patient and biologic factors, and not the anatomic and functional constraints of the remnant organ. In looking over the data, it's discouraging, I guess, to see that only about 11% of the patients under study were able to actually move on to transplantation. And I wonder if those criteria over time might be loosened a bit as we better understand both biomarker data that's able to better predict our oncologic outcomes. But I'm also struck by the SECA 1 and 2 data, whereby most patients end up recurring, but when they do recur, many were just small volume pulmonary disease that was effectively managed with salvage therapy, and produced survival data here that far exceeded what was seen with chemotherapy alone. So as with anything, specialized to this degree, I certainly wonder to what degree this will be generalizable to the population at large, but also encouraged by the fact that perhaps I might be able to shift the Dr. No role in this disease process onto the transplantation surgeons as the last and greatest hope for these patients if these outcomes sort of pan out over time in larger longitudinal studies. So wonderful presentation, and I really appreciate the perspective of the transplant team or transplant surgeons on this call. It's very exciting what you've been able to do here.
Thanks very much, James. Dr. O'Neill, what are your thoughts?
Well, thank you. And this has been a really fantastic discussion. And I think if you thought the medical oncologist was going to be the one against transplant, that's not the case. I think this is, I think this is an exciting approach for these patients who can't undergo simple surgical resection, or even complex stage surgical resection. This is the only way to cure some of these patients. I guess from a medical oncology standpoint, just some things I would point out to the group, especially those doing research. One, the outcomes tend to get compared to the entire group of patients with metastatic colon cancer, but the actual comparator group here are patients with liver-only metastatic disease, who even without surgery tend to do better than that whole group. So that needs to be paid attention to. Also, I think our best outcomes these days with multidisciplinary approaches come when we order things, chemotherapy first to assess disease biology, understand the genetics of the tumor before we go forward. So, I think this is a better approach than waiting until all else has failed and then jumping into the transplant. So I hope the group will continue to, do this under research protocols, because just the number of patients still is so small, but I think it's a really exciting area.
Thank you very much, Dr. O'Neill. I have to agree with everyone, and from my perspective, I lean towards Devin's discussion in that, I like the idea of no complications, and there really are a large number of DCDs out there that could be utilized. And I don't know if I can do this, but I'm going to try to share.
And I agree, Carlos, but DCD is not going to be the answer to fix. So your DCD increased the donor pool, but with colorectal metastasis, we're increasing the recipient.
Can you guys see this?
Yes.
Yep. So my only point in this is that These are opportunities. And what this shows is, and I cherry picked DCD donors for the last 5 years between the ages of 6 and 49. And essentially, somewhere between 40 and 52% of those organs were transplanted. And, that's even before we were doing fancy things like normothermic regional perfusions. Now, this is, to my opinion, a really important slide because this is a missed opportunity. And these are DCD donors that did not expire. They were authorized but never recovered. And this is over 3 years in just our region. The ones in red are older donors that I would have said we won't use, although Devin sounds like you would have. But essentially, there is a lot of opportunities. And if you consider that there were 27 donors in our region, and there's 11 regions with 56 organ procurement organizations, so 56 times 27 is a boatload of potential donors. And again, this is the number of complications in all comers, to include 3 mortalities and a variety of other complications in donors. And, similar to what Devin was talking about, my perspective is to try to minimize, complications. The one question I would ask Roberto, and again, I actually do believe in transplanting colorectal liver metastases, because I think what's been shown is that they do as well, if not better, than the HCC patients. But the one question, and I think the one word that everybody, or phrase that everybody has used, is the biological assessment of the disease. What is the role, Roberto, of adding something like circulating tumor DNA to your assessment? Because in your Oslo score, patients with a CEA of 0 would have been perfect. But potentially there are patients with a CEA of 0 who actually have circulating tumor DNA that actually portends towards a poor outcome. Would you consider adding that to your assessment of biology?
Yeah, that's a very good question, Carlos, and completely agree to try to keep it brief. Clearly, this is all about selection of patients, as we mentioned at the beginning, and James mentioning as well. We're super selecting the patient, and it's all about tumor biology. Nowadays, we have a lot of tools that help us to be able to see the tumor biology. We have, patients with colorectal metastasis can respond to systemic chemotherapy. We have a hepatic artery pump. We have immunotherapy that some of the patients are going through that. We have a lot of local regional therapy. We have Y90. A lot of these patients, it's a disease that we can control. The patients are not doing very well, but we can control. The biggest resection is a total hepatectomy, right? That is the biggest resection we can do. And these are why these patients are doing well, and why they have a lower recurrence or minimal recurrence in the liver, because you're replacing the liver. Now, the idea is to be able to identify more molecular markers that will be able to tell us more about the disease. Maybe we don't have to wait 1 year to decide if we want to transplant the patient, because with that 1 year, what we're trying to see is if patients going to declare themselves. And if they don't have progression, then we transplant. That is the reason of that year. That is the main reason, because that's our best prognostic factor. But if we identify that, we do a lot of translational research in the transplant team nowadays. In 7 years ago, when I moved here, we have a repository. We're doing a lot of studies with other institutions in Atlanta and also in North Carolina. And hopefully we can come with that. Now, circulating tumor cells, we have been circulating DNA. We have been testing these with Guardant 360 so far with our practice, I haven't seen a correlation. We need to collect more data. There's nothing at this moment that can tell us. And the same thing is happening with liver resections. I'm doing Guardant 360 to all our patients who go for liver resections, whether they are from surgical oncology or from the transplant surgeons. We're doing this. And we haven't been able at this moment to have a conclusion. Maybe we have around 60-something samples, and we continue every 2 months because the insurance can cover for that every 2 months in New York. And
it's all about who pays, right?
We haven't been able to come to a conclusion. but hopefully we can show something good,
Yeah.
or maybe it's not helpful, but
So
we'll see.
Roberto, we've got a couple of questions for you from the audience, and we also have Dr. McEnany and our president, Dr. Whalen, and we'll take a couple of questions. I think James has a question, and then we'll let Dr. McEnany and Dr. Whalen chime in.
Yeah, so I just wanted to weigh in about the potential for deceased donors for this particular population. I think the challenge, as Roberto alluded to, is that these patients are actively on chemotherapy, right? So how are you going to time their transplant when they've received, a cycle of chemotherapy, potentially with bevacizumab the day before, and then a deceased donor liver shows up and is available, right? I mean, that's sort of a recipe for disaster in the elective cancer world. We would wait a month or 6 weeks with bevacizumab before we would consider an operation. So I wonder how, you'd be able to negotiate that issue, because if you had a block of time where we would keep a patient off of therapy in hopes that they're going to get a liver available, well, you're certainly running the risk of progression. So that'll be one issue I would have with the deceased donor pool as a potential source of organs for colorectal liver transplantation. Second, I think circulating tumor cells are going to be a hard biomarker to use when you have a tumor in situ in the liver to be able to predict recurrence, right? I think it's probably a better utilized tool after resection if there remain residual circulating tumor cells to consider adjuvant chemotherapy in that population of patients. And that's, I know, an ongoing area of debate for, patients who are getting colorectal tumors resected, and the utility of adjuvant chemotherapy in the high-risk stage 2 population. So those were comments I had about those two issues. Thanks.
Yeah, I don't know about Devin, Roberto, but from my perspective, the reality is it's important for the patients to go through all their pre-treatment, all their surveillance assessment, and the entirety of the oncologic assessment. And then again, I really believe that if we open the door and do a better job with utilizing all DCDs to include normothermic regional perfusion, you would capture a liver within a window of time. It may not be day on the 7th or something, but I think it would be something that's doable. Devin?
Yeah, I think you wouldn't want to have 5 people with colorectal mets, all blood group O, off chemotherapy, but you could have to be strategic about it and have 1 or 2 each blood type. And right now, I think you could get them transplanted in a month to 3 months. But if more people become aggressive, it may become harder, and that could be a very challenging thing to. How long do you hold their chemotherapy for? But I think right now that you could do it if you're smart about it, and hold it and just have a few people on your wait list. Like I said, we've had over 20 open offers in the last 6 months that we could have put in anyone. You could argue that, like Roberto said, that how can you do it a lower MELD? But right now, the MELD we're using is a surrogate to predict survival. So a MELD of 19 and someone that's got quit drinking alcohol, their survival is pretty good. And you're probably the survival of your person with colorectal met is less. So that's how I'd personally justify the ethics of that you're arguing that we should transplant them because their survival is better with the liver transplant. And I'm telling you, I buy that argument. I think we agree on more things than I think it's a good indication, liver transplant. And I think someone with stable disease, the MELD of 15 or 16, if you drop to someone lower, I think the MELD doesn't accurately predict their long-term survival in those cases.
If anything, it might predict their mortality from the procedure. Dr. McEnany, have we effectively piqued your intellectual curiosity?
Absolutely. First off, Carlos, I was thinking of changing my name on this to Dekoff, fit in with the rest of the crowd that are showing up. I've got about 6 of them here on the screen. I don't know if that's a quirky computer thing or what. Like a lot of these pro-con arguments, it's always impressive how much people end up agreeing. I learned a lot tonight about transplantation. I couldn't help but think Blake, who's one of our former presidents, who would always say biology is king and selection is queen. And I think that's so much of what we were talking about here. I appreciated the chance to read the manuscript in advance. And a couple things struck me on that, going back to the original manuscript that was presented, is I wonder if in the process of properly selecting these patients, a simple thing like diagnostic laparoscopy might be of value. I noticed that one of the patients had peritoneal disease within, I think it was 90 days or so. So we do a lot of fancy other imaging. Might something like that in advance of surgery be helpful? Obviously, when you have a patient in that series who was 7 to 8 years or so out from their original diagnosis, you're dealing with different tumor biologies. I'm fascinated by the idea. We don't do liver transplant where I'm at Boston Medical Center, but so I learned quite a bit. I'm fascinated at the opportunities of transplantation being part of the surgeon's armamentarium. So thanks for letting me say a few words, Carlos. And thank you all for coming on late at night and educating us.
Can I try to answer that, Carlos?
Go right ahead, please.
Dr. McEnany, I think you touch a very important point, and this is a very key aspect. But remember, you were born and you live in a country where private medicine and insurance rule out. So a lot of the innovation comes from centers. Let's be honest. We are able to do a great job here in the US, but a lot of the innovation comes sometimes from Asia and from Europe. And then we take it and we start evolving, and then we can do it better. But it comes from there because there's too many regulations here. It's difficult to sometimes to come with innovation. Pumps started big time in Europe before coming here But well, the important thing that you're mentioning here is about that laparoscopy. And that is really more a laparotomy. That is really more a laparotomy. So if I would continue living in Canada, I will be able to take my patient, book the patient for transplant. The recipient, 3-4 days before, I'll open the abdomen, do a big laparotomy, check that there's no extrahepatic disease. I know that I have had PET scans, CT scans, MRI, you name it. But I open, I check that there's nothing. I can take lymph nodes biopsy and then send it to pathology. If it comes negative, then I do the transplant in 3, 4, 5, 1 week later. That is how Oslo is doing. That is how Canada is doing. That is how Brazil is doing. That is how Turkey is doing. How do we do in the US? First of all, to get a transplant for colorectal metastasis, you need to have an impressive, dedicated financial team in your transplant team to fight. You need to have almost a lawyer to fight with insurance and get it done. We have been successful because I have very talented people in this program, and we've been able to hire people, and we haven't able to not even fail in any of those potential candidates so far. It's a lot of work behind that. But what we do is at the moment of the transplant, we start with the recipient. We don't start with the donor because we don't want to put the risk of the donor opening the donor. So we start with the recipient. We open the abdomen. We check that there's no extrahepatic disease. We take biopsy of the lymph nodes. We take it to the pathology. If it's negative, then we bring the donor to the operating room. That is double equipoise. We'll put the risk of a donor if there's a potential good benefit for the recipient. And that is our practice that we do here in the University of Rochester. Now, you have the risk of having a patient that they read in the frozen that is negative, the lymph node, and guess what? 1 week later, it was positive, and it was negative in the frozen. It happened to us once. And guess what? One of the lymph nodes, perihepatic. The patient hasn't recovered so far in 1.5 years. That is not, what does that mean? I don't know. I don't know what does that mean, but I'm waiting for the cancer to come back. But so far, the patient is doing well. According to our protocol, if we will know in advance, I wouldn't do a transplant on that patient. So this is fascinating. It's opening, and it's going to extend. And just coming back to the DCDs, once again, I'm a big supporter of DCDs. We do DCDs here, but I don't think it's just or one or the other one. I think we need to help more patients. We're increasing the recipient pool. It's not increasing. We need more donors. We need more deceased donors. It's not only the DCDs, we need more donors. If we were Spain, if we will be Belgium, we wouldn't be talking about this, we wouldn't be having this happy hour, right? Because, you know, there's a lot of donors over there. If we were Norway, exactly the same thing. And the talk will be about, should we do transplant for colorectal metastasis or not about what type of graft we use. So clearly, there's room for everything in this process. And in good hands, the risk of a donor well selected is minimal.
I would agree. Dr. Whalen happens to be a surgical oncologist himself. How about if we give Dr. Whalen the parting shot here?
Yeah, no, I don't know. It was a great session, and I also learned a great deal and really enjoyed the back and forth on it. I think back to I was also thinking about Blake Cady and biology being king and selection being queen. The biologic bet that you make with resectional surgery of any sort for metastatic disease is that what you see is what you've got, and most of the time you're wrong. That's quite clear. The older data on resection actually, when there was ineffective chemotherapy, demonstrated that you achieved an approximately 20% overall long-term survival after this, or 5-year survival. And so, when you look at all this, you have to ask what's different. How come you can get such great, better surgery? How does that get you longer recurrence-free survival? And the answer is it's chemotherapy. It's more systemic therapies that lead you to that. It's not because yes, we're doing the surgery better, we're doing it more extensively and so forth. But that's the bet you make, that what you see is what you've got, and that's what needs to be figured out. I think before you subject, before you use a rare resource for this, right? In donor livers or ones that are ethically perhaps a little bit trickier, but as I say, it's an interesting topic. It was well done. Great job, Carlos. Thank you for taking us down this path. Thank you to everybody who stayed the night and talked.
Amen. I'd like to thank everybody, the presenters, the debaters, everyone who attended. It just harkens back to the day when we all used to sit down at our chairman's house and enjoy pizza and a beer and actually have an intellectual discussion from which we would all grow. I hope you all have a wonderful evening, and please enjoy the wonderful fall we're about to have in the Northeast. Again, thank you, everybody, and have a good night.
Thank you.
All right, thank you.
Thank you, everyone. Thank you, Carlos, and thank you, everyone.
Thank you, everybody. Bye-bye.